Good morning, everyone. Thank you for the opportunity to come here and talk a little bit about race. I'm just going to start off by giving a couple minutes on the background of race, how we got started, why we got started, and then I'll hand over to the clinical side of things. So we started working with the Shared Care Committee back in 2010, and we really were looking at ways that we could streamline patient journey as they were transitioning between primary care in the community and specialty care in the acute and ambulatory setting. So we set out with some aspirations of how we wanted to do this. We started off by doing focus groups with family physicians, specialists, and patients, and what came through loud and clear to us was a real need for improved communication, improved access to specialists for both patients, family physicians, and really to try to improve the collaboration and the relationships and the communication amongst all three groups. At that time, the pilot for RACE, which at that point was Rapid Access to Cardiology Expertise, and that was a pilot study that was done through Providence Healthcare, Department of Family Medicine, and the Department of Cardiology there, the division. And it started out because there was just no good way to really get in touch with a cardiologist. So the two groups got together, they did a small pilot study of rapid access to cardiology expertise, and it came out with some really great outcomes. And so at that point, we were just beginning our shared care work, so it made total sense to start expanding the RACE line. So back in 2010, we started with 5 specialties on the RACE line. It's now been increased to 30 specialties, most of those based on what family physicians are telling us they would like access to. We've had over 30,000 calls to the RACE line at this point, and we've also have evolved with an app. And I'll just mention the app a bit more in another slide. These are the services. You can see there, these are the services for Vancouver Coastal. We've also got almost half of those services which are provincial in nature. So they're all on the phone line. They're also all on the app, and I won't go into them, but there's quite a wide selection there. And we're continuing to bring on specialties as specialty areas come to us, as well as family physicians tell us what they'd like access to. There are RACE lines. It's across the province. It's spread to all of the health authorities. We've got Northern RACE, Kootenay Boundary RACE. They both have a telephone line structure. And in the Fraser Valley and over in Island Health, they are also using the app. So I encourage you to come out. I've got a race table out there. We'd really like you to come by and sign up for the app. It's really easy and simple to use and quite efficient for both family physicians as well as specialists. So I'll be out there for the day, as well as someone will be there tomorrow. And then lastly, I just want to put in a bit of a plug for a new prototype that we're trialing right now, again with Shared Care. And this is an email, e-consult type of a model, where it's advice, which is not necessarily urgent. RACE is the urgent, so this is a complimentary way to contact a specialist if you do have a question. It's through secure email and allows attachments. And the answer is back within 1 week. So I've also got information out there about how you can access this during our prototype phase. And on that, I'm going to pass over to Vic Huckell.
I've always wanted to be a racy cardiologist, couldn't do it, so I decided to be a race cardiologist instead. I do have a few disclosures to make, conflict of interest, if you will. Most of you know that I create, accredit, and audit educational programs for most of the specialty societies in Canada, particularly the Canadian Cardiovascular Society and the Academy, of which I'm president. I also help create and accredit joint programs for primary care physicians. However, I have no conflict of interest in this morning's presentation because I'm not talking about any pharmaceutical companies or devices. The RACE line is an amazing tool from my perspective. It gives me the opportunity to actually talk directly to a primary care physician and discuss issues that are of concern to them and to me, rather than me doing the usual 4-page written letter, which nobody ever reads. So at the end of each RACE call, I also try to dictate a small summary, which I'll send back to the physician online so they have a summary of the issues that I've raised. So with that as background, let me show you a few of the cases that we've actually dealt with in the last year. I received a call about a 49-year-old male patient who had a hypertrophic cardiomyopathy. He was asymptomatic. One of the issues, of course, is that people with HOCM can die suddenly. So the family physician said, I have this gentleman in my practice who had non-cardiac chest pain. He had had a negative treadmill test in the last 6 months. However, he was hypertensive and felt to be on appropriate medications. The patient came in and said, I have erectile dysfunction, or ED, and I would like to use a PDE5 inhibitor. A lot of people aren't aware of the fact that in some individuals, such agents actually can have an impact on blood pressure. This family physician was incredibly astute because she realized that sometimes when you have hokum, if you lower the blood pressure, the patient can die on you. So she said to me, can I actually use Cialis in this particular individual? The patient was not on any nitrate-containing products. And so the family physician said, is any other test needed before I initiate PDE5 therapy, and can this individual use Cialis? So we had a good discussion about the medications the patient was on, none, and we talked about the issue of orthostatic hypotension and protection of the patient, and I said, go ahead and use it. The patient does not need to be seen again by a cardiologist. So I followed up with a phone call at my own request to find out how the patient did. And the patient had used Cialis without any side effects at all, and then I sent the information on to the individual's usual cardiologist. To me, that's a save of money, because this individual did not have to have another visit with their cardiologist. This individual did not have to go to the emergency department. A second phone call, a 48-year-old female who has known hypertension, who is asymptomatic and on reasonable medications. The blood pressure in the office was measured at 151 on 90. Now, for those of you who work with me, I'll say two things, and you'll recognize this. One, this blood pressure was clearly measured with an electronic device. How do I know that? Because there's a 1 in the number, and we never do manuals with ones, okay? Two, you'll say, I better increase the blood pressure medications, and my response, of course, is we have abandoned making the diagnosis and monitoring hypertension with office measurements. There's a big trap in that. Invite me back to do a workshop. But the more important question was that the patient had had an ECG done, and the computer interpreted the ECG as an acute myocardial infarction of indeterminate age. Come on, it's either acute or old or indeterminate. So the question was, should I send this individual to the emergency department? And that's a very reasonable question. Think about it for a second. What would you have done? You're sitting there with a patient, asymptomatic, and the ECG says acute myocardial infarction. So I did what a reasonable person would do. I'd say, is the patient asymptomatic? Should you send the patient here? No, send me the ECG. So the patient ECG was faxed to me. I had a look at it, and whoever did the ECG had reversed the limb leads. Okay? So I said, well, why don't you repeat the ECG? Which was done 5 minutes later, and guess what? The repeat ECG was normal. So again, we saved a visit to the emergency department, and the hackles on the back of the family physician's neck went down because it was not an acute or indeterminate myocardial infarction. In addition, we deal with small, isolated communities. So I received a phone call from an isolated northern community, and this community had very limited resources available to treat an individual. There was a diabetic 42-year-old female. She came into the nursing station saying, I feel unwell, and she had not been taking any of her medications. Again, as a sidebar comment, you all know that certain ethnic groups are notorious for really not understanding the body, having a different time sense than us, and really not wanting to take a lot of medications. So in the station, the blood pressure was okay, 143/84, electronic device, see the 3, but the patient looked unwell. And the patient was complaining of sort of unusual back pressure, but also a little bit of frontal chest pain. There was a 12-lead ECG available, which was done in the nursing station, but there was no computer interpretation, no blood work available. So again, put yourself in this perspective. You're in an isolated community with limited resources, and you want to know what to do. So the nurse practitioner said appropriately, transferring this patient out would be challenging. Should I be conservative or aggressive in my management, and can I wait just to send out blood tests? So again, the question then becomes, what can we do to expedite care in somebody who may be critically ill? So I said, what medications is the patient supposed to be on but not taking? And it turns out the patient was supposed to be taking diabetic medications, anti-ischemic therapy, blood pressure pills, and antiplatelet, none of which were being taken. That's a signal to me that this individual likely has significant atherosclerotic disease. So I suggested to the nurse practitioner that she initiate an ACS protocol, but send me the ECG. Because again, being able to interpret the information is very powerful. And guess what? This time around, with a correctly done ECG, this person was having an acute transmural myocardial infarction. So the only recommendation I can make is please arrange medevac right away, because this patient is in big trouble. So medevac was arranged to the closest tertiary center, which happened to be in Alberta, because this is a very isolated northern community. And when the patient arrived, ACS, acute coronary syndrome, was confirmed, and angioplasty was successfully performed, a resolution of the symptoms, and the patient is now back home, and I followed up because I like to find out how they did. And the patient said, yeah, you know what, doc, I guess I better take my pills. My prediction is, because this patient is now on 12 different medications, it isn't going to happen. But at least in that context, I think we did something good. Some other sort of minor quickies so the rest of my team can also speak to you. A common phone call is, doctor, I have a patient who's in heart failure and the rate is suddenly going up. Get rid of the canned soups. The patient that they asked me about was having 2 cans of prepared soup every day. And you know what? The advice worked. I had a phone call about a PR interval prolongation in a 90-year-old. The PR interval was normal at less than 200. This was 220 milliseconds. Guess what? The PR interval gets longer as you get older. Leave the patient alone. A common question that we get is prolonged QT intervals. Step one, of course, in all of these that I get is to actually look at the ECG, because computers are stupid and they sometimes measure strange things. So you want to be sure that the QT interval is really, truly prolonged. And if it really is prolonged, we initiate a protocol of avoiding life-threatening medications and sending the information on to our inherited arrhythmia group, which is a relatively new group in our province. So a common question is, Huckell, I have a patient who is now in atrial fibrillation. Should I anticoagulate them? Right? You hear this all the time. And the answer from the Canadian Cardiovascular Society is simple. If you're over 65, you're bloody right, you should anticoagulate them. And if you're under 65, you start looking at other things. We will get phone calls all the time about severe valvular heart disease and management, and we tell them what to do in terms of investigations. And finally, we will get a lot of phone calls about interpretation of Holters. For example, I had a Holter sent to me from a family physician, and the patient was having asymptomatic 5-second pauses. Think about it. The heart stops that long, not good. Better send the patient on to be done. Thank you very much.
Good morning, everyone. Thanks for having me this morning. I also have no conflicts of interest in terms of the cases that I'm going to present this morning. I also have 3 cases. I try to pick them as some of them that are very common cases that we get through the race line, and some of them as ones that I thought are more emergent and needs more urgent attention by us or needs a referral to emergency department. So this is a very common call that we get. Typically, when I'm on race line, which we typically do when we are on call for either St. Paul's or VGH rheumatology, I probably get 2 or 3 of them every week that I'm on call. So this is a 79-year-old woman who presented to the family physician with 2 days history of sharp right-sided temporal and occipital headaches. She has a past medical history of hypertension, diabetes, and hypothyroidism. So I got this call, and the family doctor already gathered some history. So there was no visual changes. She had no previous history of chronic or syndromic headaches. There was no symptoms suggestive of polymyalgia rheumatica, or there was no history of such. The questions that were posed to me were, is this GCA, or giant cell arteritis or temporal arteritis? Should I start high-dose steroid at this point, or should I wait for a biopsy first? Does she need pulse steroid? Does she need IV steroids? Does she need to go to the hospital? And questions about temporal artery biopsy, how can I organize it, when should it be done, how long can I wait after treatment. So we gathered more information from the patient. So on further questioning, there was history of other associated symptoms such as jaw claudication. ESR was pending at the time. She just had a test. So my advice was please arrange an urgent temporal artery biopsy. I typically ask, when I want to arrange for one, I typically ask the vascular surgeon on call at either Vancouver General or St. Paul's Hospital. Different hospitals have different surgeons who do the temporal artery biopsy. In some hospitals, ENT does it. In some hospitals, ophthalmologists do it. So if you don't have access to VGH or St. Paul's, it's better to find out who is responsible for doing the temporal artery biopsy in your closest hospital. So basically, the first advice was to arrange for an urgent temporal artery biopsy. This history was suspicious enough for me to ask them to start high-dose prednisone. Typically, we say 1 milligram per kg, but for an average person, that ends up being around 50 milligram, 50 milligram per day. You would like to have the biopsy for about 2 to 3 weeks. That's the textbook answer usually. That's the time you want to get the biopsy done. In this case, there was no need for pulse steroids because there was no visual changes. But if there is a visual changes, you want to ask the patient to go to the hospital so they get 1 gram of methylprednisone. So that's the indication for pulse steroids, which is typically 3 days of IV steroids, and then to transition to high-dose steroids. She was started on 50 milligram of prednisone. I typically follow up with a phone call, or if they are local, I try to see them in the office as well. So follow-up was arranged in the office. So her outcomes was that her ESR came out as being 100. Temporal artery was positive for giant cell arteritis. She was started on tapering schedule of prednisone. We have some evidence for using aspirin for prevention of stroke in this group of patients, so she was started on low-dose aspirin as well. Case number 2 was a patient who was known to have a history of lupus. Her disease manifestations included skin findings such as malar rash in the past, leukopenia, and she had positive serologies of ANA. She was on hydroxychloroquine as her mainstay of therapy before. She was monitoring disease activity blood tests every 6 to 8 weeks, as well as urine tests. She presented to her family physician with history of malaise, nausea, and fever. Her latest blood work, which was done a few days before, showed creatinine, which was significantly higher than her baseline at 300. Urine showed protein. Double-stranded DNA, which we typically use for disease monitoring, was elevated, and her C3 and C4 complements were low. So the question was, is this a lupus flare, or what's the best course of action at this point? And what further investigations needs to be done? So in terms of further questioning, I asked if their vitals are stable. She had borderline fever in the office, no focal infectious symptoms. She had a prominent malar rash, which wasn't typical before. So basically, this was very suspicious for a lupus flare-up, and especially lupus nephritis. And this is one of the indications that you want to treat the patient urgently. So I asked the patient to be sent to St. Paul's Hospital Emergency Department to get admitted under internal medicine and followed up by our service. So in terms of outcome, patient was found to have 2.5 gram of protein per day in her urine. A renal biopsy was arranged by the nephrology team, and her infectious workup was negative. Biopsy showed class 4 lupus nephritis, and this patient received pulse IV steroids as well as IV cyclophosphamide, and then transitioned to steroid-sparing agents. The third call is These are the calls we typically get from communities who do not have a local rheumatologist, and they usually pertain to inflammatory arthritis management. So this is a call I received from a nurse practitioner from a community in northern BC. She was a 20-year-old female, otherwise healthy, presented with 5-week history of swollen joints. Distributions were in the MCP in the hands and MTPs in her feet. She was previously treated with naproxen with some benefit and improvement. She had some preliminary tests already done by the time I received the call. The rheumatoid factor was 50, which is high, and CRP was 30, which is again significantly high. The questions that was posed to me was, what other tests should I order? Is this rheumatoid arthritis? Other tests than that we need to do as a baseline if we want to treat this patient, and which medication to start with. So my advice was arrange for anti-CCP test, viral hepatitis workup for our baseline in terms of starting the patient on disease-modifying agents, X-rays to look for any damage to the joints already or erosions or signs of inflammatory arthritis, and baseline liver enzymes to see if they're safe to be started on any of the disease-modifying agents. My other part of advice was, because she didn't have significant improvement and still has some residual pain, to start the patient on prednisone. We typically use 1,515 milligram lowish dose for inflammatory arthritis, and it should be enough for treating inflammatory arthritis for 10 days, and then taper usually by 5 milligram every 10 days. And I arranged for a phone follow-up in about a week to see how she's doing and review their test results. So outcomes of this case, her anti-CCP was also positive. Hepatitis B and C negative, baseline enzymes, liver enzymes were normal. She improved significantly on prednisone. That's another signal that we are dealing with an inflammatory arthritis. Phone visit follow-up she was started on methotrexate, and I connected that patient with our traveling clinic, which goes to Northern Community. Thank you.
Good morning. Thank you for having me. Okay, so these are 3 cases that I took from the last time I was on call, and I thought they were pretty representative of the kind of calls I usually get. Okay, so the first call I got was from a hospitalist working in a hospital in Whitehorse, regarding an 81-year-old woman who had been admitted several weeks prior with severe back pain, which was ultimately found to be 2 new vertebral compression fractures. Now, this is on the background of several prior fractures. She'd actually had a tibial plateau fracture in 2012 and again in 2013. And then in March of this year, she had a low trauma hip fracture, which was surgically repaired. It turns out that this is on the background of a history of chronic prednisone use for pulmonary fibrosis. Now, she was appropriately started on a bisphosphonate, alendronate, in 2012 after her initial tibial plateau fracture, as well as calcium and vitamin D. Now, I didn't know this, but it turns out that in the Yukon, they don't have any access to bone density testing. So even though she was started on therapy in 2012, we don't have a baseline BMD. And she was sent down to Vancouver in January 2017 and found to have pretty severe osteoporosis, which is not surprising given her fracture history, with the lowest T-score being minus 4.7 at the femoral neck. So the question that this hospitalist had for me was, how should I treat this severe osteoporosis? We had the following discussion. 1, was the patient compliant with her oral alendronate? And as far as the physician knew, they were. We discussed things that can cause failure of bisphosphonate therapy. So has there been a development of secondary processes that are making the bone density worse? So we already knew that the patient did not have osteomalacia. Her vitamin D level was good. Her creatinine was good. But I recommended that they get a fasting calcium. That wasn't done previously. And that was to make sure she didn't have primary hyperparathyroidism, and then get an SPEP and a UPEP to rule out multiple myeloma. And then we went on to discuss how to treat this patient best. So given her fracture history and extremely low bone density, I felt that she'd be the ideal candidate for Forteo. This is the only currently available anabolic agent, which is a daily injection licensed for 2 years, and then you have to follow that up with anti-resorptive therapy. The trouble with Forteo is that it's extremely expensive. It's about $7,000 for the year. So we talked about coverage for this patient. Now, she was from Native background and was covered under Native Affairs, so I recommended that as a first place, the physician try to access her Forteo through Native Affairs. If that failed, Forteo does have a customer care program, which will lobby for the patient with whatever extended health benefits they have, if they have it, or even Native Affairs, to at least get partial coverage, and sometimes they will provide compassionate release of the drug. So that was the second line thing that I recommended. If those avenues failed, we discussed that she should start either Prolia or IV zoledronic acid, which are both potent anti-resorptive agents and are taken parenterally. So in case compliance actually is an issue with an oral bisphosphonate, this ensures that the patient gets the drug. If there's any issues with absorption, again, this ensures that the patient gets the drug. The second call was regarding a 31-year-old woman who was 11 weeks pregnant, and her first trimester blood work showed that she had mild hyperthyroidism with a free T4 of 24, with 20 being the upper limit of normal, and she was relatively asymptomatic. So the question that the GP had for me was whether this pattern of blood work was consistent with just physiologic changes of pregnancy or whether there was additional pathology here. So as you probably know, as the HCG levels rise in the first trimester, and they actually peak in the first trimester, the TSH drops physiologically, and that's because there's homology between HCG and TSH, so that the HCG can co-stimulate the TSH receptor, and so you can maintain normal thyroid hormone levels with a relatively lower TSH. In that just physiologic, with that physiologic change, we don't generally see the TSH being overtly suppressed, and we don't expect to see the free T4 being elevated. However, under circumstances where the HCG levels are higher than a normal pregnancy, such as a molar pregnancy, multiple gestations, or pretty severe nausea and vomiting, the HCG can be higher than in a normal pregnancy and can cause transient gestational thyrotoxicosis. So we discussed whether she had a viable pregnancy, yes. Singleton pregnancy, yes. She actually had a lot of nausea, vomiting in the first trimester, not meeting criteria for hospital admission for hyperemesis gravidarum, but still pretty significant. And in her background, she had no prior history of any hyperthyroidism to suggest a pre-existing Graves' disease. So on the differential, I said, well, this could be gestational hyperthyroidism related to her nausea and vomiting, but she could also have mild Graves' disease. I didn't have a free T3, so I recommended that the family physician get that because that can be disproportionately elevated in Graves' disease. And I asked for TSH receptor antibodies to be ordered to help differentiate between just transient HCG fluctuations or mild Graves' disease. And you know that you cannot use radioactive iodine in a pregnant woman or you will destroy fetal tissue and cause congenital hypothyroidism. We discussed that if this were Graves' disease, at present it's mild, and I would just watch and wait and I would not treat this woman. And the reason for that is because antithyroid medications do cross the placenta, and so in treating mom, you actually end up potentially over-treating the fetus. So even if we decide to start medications in pregnancy, our goal is to keep mom just slightly hyperthyroid to prevent oversuppression of the fetal thyroid. And she is just slightly hyperthyroid on her own. And then I arranged a follow-up appointment in my office 1 week later, at which point I expected these additional labs to be available. And by the time I saw her, her free T4 was already in the normal range, her T3 was in the normal range, but her TSH receptor antibodies were mildly positive. So she did actually manifest mild Graves' disease in pregnancy, and we're just following her monthly. And then this final call was from a family physician somewhere on the island. I can't remember where. It was a small community, regarding a 68-year-old man who presented to his family doctor complaining of a lot of pain and irritation in the eyes, and they were quite red and swollen, the GP said. And there was also restriction of lateral movement, although the patient was not complaining of diplopia. Screening labs showed that he was hyperthyroid with a free T4 of 32, although other than eye complaints, he didn't complain of any other hyperthyroid symptoms. A radioactive iodine uptake and scan was arranged, which showed inhomogeneous uptake throughout the gland, and it was reported as being consistent with toxic multinodular goiter. The family doctor then ordered a thyroid ultrasound, which showed a dominant nodule of 1.6 centimeters in the left lobe. But sometime after that, the TSH receptor antibodies came back, and these were very, very elevated at 11.2, upper limit of normal being 1.8 or less. So the GP was a little bit confused about these conflicting results of the radioactive iodine uptake and scan and the antibodies, and wanted to know, what is this? Is this toxic multinodular goiter or Graves' disease? And then the GP was also planning to treat this patient with radioactive iodine and just wanted to make sure that that was okay. So the discussion I had was that the TSH receptor antibodies here win out. They're 95% sensitive and specific to Graves' disease, and they clinch your diagnosis. That combined with his eye complaints is Graves' disease. I think the radioactive iodine uptake and scan was confusing, and I think what was happening was that the person had global uptake, except for in areas where he had cold nodules. And that was giving that patchy, homogeneous pattern, which was then misinterpreted as a toxic multinodular goiter. But it was actually cold spots with the nodules and not hot spots with hyperfunctioning nodules. So I had recommended that he hold off radioactive iodine for a couple of reasons, and we discussed starting methimazole to make the patient euthyroid first. So in the setting of cold nodules, the one that's 1.6 centimeters is substantial and should be biopsied. If you give somebody radioactive iodine first and then go to biopsy that nodule, there's going to be a lot of inflammatory changes, which will make the cytology very difficult to interpret. So that's reason number one. Reason number two is this patient had quite significant eye complaints, and radioactive iodine does exacerbate Graves' ophthalmopathy. So before even considering radioactive iodine in this person, he should be seen by an ophthalmologist, preferably one that specializes in Graves' ophthalmopathy, to weigh in on just how severe the ophthalmopathy is. Because if it's moderate or severe, it would be contraindicated to use radioactive iodine, and then your options are drugs or surgery. And if it's considered mild, then you can consider radioactive iodine if you give the person steroids in the background. And then as a final thing, we talked about, since we're going to be starting methimazole, I gave counseling about agranulocytosis that should be conveyed to the patient. Okay, so those are my 3 cases, and I think we have some time for questions.